Is your skincare making your skin worse? How to tell purging from damage. There is one skincare diagnosis that is extremely convenient for the beauty industry: purging. You buy a new product, your face breaks out, the product appears to be making your skin worse, but instead of stopping, you are told this is good news. It is bringing everything to the surface, your skin is detoxifying. It has to get worse before it gets better. How fortunate for the product. If it improves your skin, it works. If it makes your skin worse, it is also apparently working. That is an excellent business model. But is purging genuinely supported by clinical evidence, or has it become a reassuring label for every bad reaction? Because a face covered in new bumps could represent several very different conditions. It might be an ordinary acne flare that has nothing to do with the product. It might be follicular occlusion caused by the formulation. It might be irritant contact dermatitis from using too much, too often. Contact dermatitis. It might be manageable, early retinoid irritation, or it might be a reaction that needs medical attention. Look frustratingly similar in the bathroom mirror, but they do not feel the same, behave the same, or require the same response. So today I'm going to show you how I distinguish them clinically. We will look at what the lesions resemble, whether the skin itches or burns, where the reaction appears, how quickly it develops, and which warning signs mean you should stop listening to skincare advice and seek medical care. And I want to begin with a surprising scientific fact. Clinical trials do not show that topical retinoids routinely make acne worse before making it better. So if your skin is staging a rebellion, keep going, it's purging should not be the automatic verdict. I'm Dr. Low Chai Ling, an aesthetic doctor at SW1 Clinic, and this is Skin Honestly. Today we are putting purging on trial, prosecution. In skincare language, purging describes a temporary increase in visible acne after beginning an ingredient that affects follicular cell turnover. The theory is that pre-existing microcomedones, the microscopic precursors of acne, become clinically visible more quickly. This is biologically plausible, but plausible does not mean common, inevitable, or proven in every person who develops bumps after beginning a product. A review published in the Journal of Drugs in Dermatology examined clinical trial evidence to determine whether topical retinoids genuinely cause an initial acne flare. The doctors found little evidence that they routinely do. Another analysis examined 3 multi-center, double-blind, randomized, phase 3 trials involving a tretinoin-containing acne treatment. Again, the investigators did not find evidence of a consistent early worsening of inflammatory acne. That does not prove an initial flare can never occur. Acne naturally fluctuates, pre-existing lesions may become visible, a new product may contribute to occlusion, and irritation can produce bumps that are mistaken for acne. But significant worsening is not a compulsory initiation ceremony. Your skin does not need to become dramatically worse to prove that a retinoid is working. Before accepting the word purging, I ask 5 questions. What do the lesions look like? Where have they appeared? Does the skin itch or burn? When did the reaction begin? And are there symptoms beyond the skin? Those 5 questions can completely change the diagnosis. Let us examine the first clinical pattern, the ordinary acne flare. A common patient presentation is someone who has experienced acne for years, often around the chin, jawline, cheeks, or forehead. She begins a new product. Several days later, inflammatory spots appear in the same places where she usually breaks out. There is no diffuse redness. There is no significant itching, burning, scaling, or swelling. Blackheads or whiteheads may also be present. Because the product is new, it receives the blame. But visible acne lesions do not suddenly materialize from nothing. They begin developing microscopically before we see them. A product applied on Monday may be blamed for a pimple that appears on Wednesday, even though that lesion was already forming beneath the skin. Human beings are very good at confusing sequence with causation. This happened after that quickly becomes this happened because of that. An ordinary acne flare becomes more likely when the lesions occur in familiar acne-prone areas, comedones, blackheads or whiteheads are present, the eruption resembles the patient's usual acne, there is little or no itching, the surrounding skin is not diffusely red, cracked, or weeping, the flare follows a hormonal, menstrual, or stress-related pattern. Acne is not simply an infection. Its biology includes abnormal follicular keratinization, increased sebum production, inflammation, and the activity of Cutibacterium acnes. Hormonal signaling can also influence sebum and inflammation, particularly in adult female acne. This is why evidence-based acne treatment often combines different mechanisms of action. The 2024 American Academy of Dermatology Acne Guidelines supports treatments including topical retinoids, benzoyl peroxide, salicylic acid, and azelaic acid for appropriate patients. The correct treatment depends on lesion type, severity, distribution, scarring risk, and the patient's individual medical circumstances. The important point is that acne has recognizable morphology. Comedones strongly favor acne. Diffuse itching, burning, and eczema point us in another direction. My clinical verdict: a new product appearing shortly before a breakout is a suspect, not a conviction. Your calendar can identify correlation, it cannot diagnose causation. 2. The burning phase. The next pattern I commonly see is a patient who has mistaken cumulative irritation for purging. Her skin is red, tight, and burning. Products that previously felt comfortable now sting. Sometimes even water hurts. She may have started a retinoid, exfoliating toner, and vitamin C within the same week, or she has increased the frequency of a strong product because she wants faster results. The bumps may be small and red, so she assumes they are acne being brought to the surface. But on examination, the surrounding skin is inflamed, dry, and scaly. This pattern is more consistent with irritant contact dermatitis. Irritant contact dermatitis occurs when chemical or physical exposure directly disrupts and injures the skin barrier. It does not require a specific immune allergy. Its biology can involve disruption of the stratum corneum, epidermal injury, inflammatory cytokine release, and activation of nerve endings. That is why burning and stinging are often prominent. An ingredient can be clinically useful and still be irritating. Salicylic acid can help treat acne and comedones. Glycolic acid increases exfoliation. Azelaic acid may be useful for acne, rosacea, and pigmentation. Retinoids have strong evidence for acne and photoaging. But the skin does not assess each product in isolation. It experiences the total chemical burden. Concentration matters, frequency matters, formulation matters. The number of active ingredients matters. And the condition of the skin barrier before treatment matters. 4 products that are individually tolerable may become intolerable when layered together. Clinical clues such as irritant contact dermatitis includes burning or stinging that's more prominent than itching, redness corresponding to repeatedly treated areas, tight, tender, or raw feeling skin, dryness, scaling, or superficial cracks, previously tolerated products suddenly stinging, symptoms beginning after increasing strength or frequency, several exfoliating and potentially irritating products being combined. Irritation is generally dose dependent. The greater the exposure, the greater the likelihood of barrier injury. This differs from allergic contact dermatitis, in which a sensitized person may react to a very small amount of a particular allergen. The correct response is not necessarily to declare every active ingredient permanently unsuitable. First, the inflammation needs to settle. Then, if clinically appropriate, products can be evaluated and reintroduced carefully, one important variable at a time. My clinical verdict: burning, tightness, and diffuse scaling are not evidence that hidden acne is successfully escaping. They are signs that the skin barrier may be overwhelmed. Your skincare routine should improve your skin, not make washing your face feel like a chemical interrogation. 3. The itchy, swollen face. Now consider a different patient. Her main symptom is not burning, it is itching. Her eyelids may be swollen and flaky. The rash may extend across the face or neck. It appeared a day or two after she introduced a new cosmetic, sunscreen, fragrance, or hair product. She says, "But I have used this product before. I cannot be allergic." Previous tolerance does not exclude allergy. Allergic contact dermatitis is a delayed T-cell mediated immune reaction. The immune system must first become sensitized to an allergen. Sensitization may develop after repeated exposure. Someone can therefore use the product for months or even years before developing allergic contact dermatitis. Potential cosmetic allergens include fragrances, preservatives, hair dye chemicals, adhesives, and certain botanical ingredients. Natural is not the opposite of allergenic. Poison ivy is natural, so are mosquitoes. Nature has never promised hypoallergenic customer service. The eyelids are particularly vulnerable because their skin is thin and allergens may be transferred from other sides. An eyelid reaction may come in the form of an eye cream, but it can also originate from shampoo, fragrance, nail products, hair dye, or substances transferred by the fingers. Clinical clues suggesting allergic contact dermatitis include itching that is more prominent than burning, delayed onset after exposure, eczematous redness, scaling or weeping, significant eyelid or facial swelling, a rash extending beyond the precise application boundary, recurrence following re-exposure, a product that was previously tolerated. Appearance alone cannot always distinguish allergic from irritant contact dermatitis. This is where patch testing becomes important. Patch testing investigates delayed contact allergy by applying controlled amounts of standardized allergens to the back. The sites are then assessed at specific intervals for delayed reactions, placing a cosmetic behind your ear for 10 minutes. Depending on the history, formal testing may include a baseline allergen series, cosmetic allergens, and selected ingredients from the patient's own products. A positive result will still require interpretation. The immune system reacted to the tested substance. We must then establish whether the patient was exposed to that allergen in a clinically relevant way. Similarly, a negative standard patch test does not rule out every possible allergy. The relevant substance may not have been tested, or the reaction may be irritant rather than allergic. My clinical verdict: I used it before. Does not prove that a product will remain safe for you forever. Sometimes the immune system needs several meetings before deciding it dislikes someone. Or the mystery forehead bumps. Another patient comes in with numerous small bumps across her forehead and temples. They appeared gradually after she introduced a rich facial balm or started using a new hair oil. The bumps are relatively uniform. They are not particularly itchy. The surrounding skin is not diffusely red, burning, or eczematous. This pattern raises the possibility of product-related follicular occlusion, sometimes described as acne cosmetica. Hair oils and pomades may contribute to acne around the forehead and hairline in susceptible patients. The patient is often confused because the product is labeled non-comedogenic, but non-comedogenic is not an absolute guarantee. At the same time, we should not rely too heavily on online ingredient rating charts. Many websites assign every ingredient a comedogenicity score from 0 to 5. The rating looks beautifully scientific. The evidence behind it is considerably messier. Some historical comedogenicity ratings were derived from animal models, particularly rabbit ear tests, or from raw ingredients at concentrations that do not resemble a finished cosmetic product. The behavior of one isolated ingredient does not reliably predict the behavior of the complete formulation. A human study published in the Journal of American Academy of Dermatology reassessed finished cosmetic formulations containing ingredients historically classified as comedogenic. The finished products did not necessarily produce the response predicted by those ingredient lists. Formulation matters, concentration matters, the vehicle matters, the length of skin contact matters, and the individual patient matters. I would definitely not throw away a product simply because an ingredient tracking website has placed a red warning beside one emollient. Your face is not a rabbit ear. However, the clinical distribution remains useful. If small closed comedones repeatedly develop exactly where a leave-on product or hair product touches the skin and improves when that exposure is removed, the product remains a reasonable suspect. Occlusion may also interact with friction, heat, and sweat. This can contribute to breakouts beneath tight masks, helmets, and other occlusive equipment. Clues suggesting product-related occlusion include numerous small relative uniform closed comedones linked to the cosmetic or hair product, forehead and hairline involvement following hair oils or pomades, development over days or weeks rather than minutes, or diffuse inflammation, removing the suspected exposure. My clinical verdict: non-comedogenic lowers suspicion. It does not establish innocence. Marketing language is not a force field around your pores. The retinoid adjustment. A patient begins tretinoin or another topical retinoid. During the first few weeks, she develops mild dryness and fine flaking. Her skin feels slightly tight. She notices transient stinging after cleansing. The symptoms are limited to treated areas and improve when the application frequency and moisturizing routine are adjusted. This can be consistent with manageable early retinoid irritation. Topical retinoids are important acne treatments because they help normalize follicular keratinization and prevent microcomedonal formation. They also have anti-inflammatory effects, but they can cause retinoid dermatitis. Typical symptoms include erythema, dryness, scaling, stinging, and burning. A systematic review of topical retinoids found that clinically significant irritation was generally uncommon, but individual tolerability varied. The sensitivity of a patient's skin can influence tolerability as much as the particular retinoid selected. Mild early irritation does not necessarily mean treatment must be abandoned permanently. Product management may involve reducing application frequency, using an appropriate amount, applying it to completely dry skin, adjusting moisturizer use, removing other exfoliating products, using short contact treatment when clinically appropriate, choosing a different strength, formulation, or retinoid. Evidence-based guidance suggests that potentially irritating acne treatments may sometimes be introduced through alternate day or short contact application. But there is an important difference between maladaptation and significant injury. More consistent with manageable early retinoid irritation, mild dryness, fine flaking, slight tightness, transient stinging, symptoms limited mainly to treated areas, improvement after adjusting the regimen. Less consistent with an acceptable adjustment include severe or persistent burning, marked diffuse redness, significant swelling, crusting, fissures or blistering, eczema spreading beyond treated areas, severe pain, continued deterioration despite reducing exposure does not make the skin adapt faster. It mainly makes the tube empty faster. My clinical verdict: mild early retinoid irritation can often be managed. Severe inflammation should not be romanticized as evidence that the treatment is really working. Push through it is excellent advice for finishing a difficult workout. It is not a universal dermatology protocol. Patient pattern 6, the reaction that should not wait. The final category should never be diagnosed through a social media poll. A patient applies a new product and develops rapidly progressing facial swelling. Her lips or tongue begin to swell. Her throat feels tight. There's difficulty breathing or swallowing. This is not purging. It is not expected retinoid irritation, and it is not a damaged skin barrier that should be treated with a ceramide serum and patience. Difficulty breathing or swallowing or swelling involving the tongue or throat requires emergency medical attention. There are other warning signs. A widespread, painful rash with blistering or skin peeling may indicate a serious cutaneous reaction. A rash involving the eyes, mouth, or genital mucosa needs urgent assessment. Fever, facial swelling, and a rapidly spreading rash after starting a medication can indicate a serious drug reaction. Increasing pain, warmth, swelling, pus, golden crusting, or fever may suggest secondary infection. Eye pain or changes in vision should never be treated as an ordinary cosmetic reaction. Seek urgent or emergency care for difficulty breathing or swallowing, swelling of the tongue or throat, rapidly progressing facial or lip swelling, faintness, wheezing, or other signs of anaphylaxis, widespread blistering or skin peeling, severe skin pain, a rash involving the eyes or mouth, fever or systemic illness accompanying the rash, signs of a significant infection, eye pain, or changes in vision, rapid deterioration. For a mild local reaction, the first sensible step is usually to stop the most recently introduced non-essential product. Do not try to neutralize one active ingredient with another. Your face is not a chemistry practical. And do not introduce 5 new soothing products at once. Soothing products can also contain fragrances, preservatives, and botanical extracts that may cause irritation or allergy. When the skin is filing a complaint, adding more witnesses does not necessarily help the investigation. My clinical verdict: if a reaction affects breathing, swallowing, vision, mucous membranes, or your general health, stop troubleshooting your skincare routine and seek medical care. Checklist. Let us make this practical. If your skin worsens after starting a product, ask yourself these 6 questions. 1. Does it itch or burn? Prominent burning and stinging favor irritation. Intense itching, especially with eczema and swelling, raises suspicion for allergy. This is not absolute, but it is a useful clue. 2. Are there comedones? Blackheads and whiteheads support acne. Dermatitis generally does not produce true comedones. Surrounding skin normal. Individual pimples on otherwise normal skin suggest acne. Diffuse redness, scaling, tightness, weeping, or tenderness point towards dermatitis. Did it appear? Acne often follows familiar acne-prone areas. Irritation usually corresponds closely with repeated product application. Allergic dermatitis may spread beyond that boundary and may follow the hairline or another area of repeated contact. Again, rapid burning following a strong product suggests direct irritation. A delayed itchy eruption may suggest allergic contact dermatitis. Comedomal occlusion usually develops over days or weeks. Timing is informative, but timing alone does not prove causation. Anything happening beyond the skin? Breathing difficulty, throat tightness, fever, severe swelling, mucosal involvement, significant pain, or visual symptoms require medical assessment. A suspected product reaction. First, stop the most recently introduced non-essential product. Second, do not add another active ingredient to counteract it. Third, temporarily simplify the routine. The exact plan depends on the diagnosis and severity, but applying exfoliating acids, scrubs, retinoids, and fragrance products to already inflamed skin rarely helps clarify the problem. Fourth, document the timeline. Take clear photographs, write down when each product was introduced, how frequently it was used, and where it was applied. Keep the packaging and complete ingredient list. Fifth, seek clinical assessment if the reaction is severe, persistent, recurrent, or unclear. If allergic contact dermatitis is suspected, formal patch testing may be more useful than permanently banning 20 ingredients based on guesswork. And when reintroducing skincare in the future, change one important variable at a time. That approach may be less exciting than implying an entire new routine on Sunday evening, but it allows you to identify what is helping and what is fouling the complaint. Not every breakout is purging. Not every burning sensation is a damage barrier. Not every itchy rash is an allergy, and not every product labeled non-comedogenic will suit every acne-prone patient. An ordinary acne flare tends to produce recognizable acne lesions in familiar areas. Irritant contact dermatitis often burns and follows cumulative exposure. Allergic contact dermatitis frequently itches, may be delayed, and may require patch testing. Product-related occlusion can produce small comedones in areas of repeated contact. Early retinoid irritation may cause manageable dryness and scaling, but severe inflammation is not a compulsory part of treatment. And breathing difficulty, mucosal involvement, widespread blistering, fever, severe swelling, or visual symptoms require medical attention. Please stop calling every worsening skin reaction purging. Sometimes your skin is adjusting, sometimes it is breaking out, sometimes it is irritated, sometimes it is allergic, and sometimes it is asking you very clearly to stop. If this episode helped, follow Skin Honestly and send it to the friend who has been pushing through a reaction since February. Then send me your skincare mystery. What did you think was purging but later discovered was something else? Your experience may be discussed anonymously in a future episode. I'm Dr. Low Chai Ling. Question extraordinary claims, introduce your active ingredients carefully, and remember, your face should not have to catch fire before your skincare is considered effective. Until next time.